Journal of the American Medical Association recently reported that 51.3% of the respondents to a large public survey did not know whether medical aid in dying was legal anywhere in the United States. A similar number of people don't know whether or not it's legal in their state. So if any of you are in that latter category, we're going to be educating you today. Barbara Morris is going to be speaking with us, and she is a geriatrician and one of the founding members of End of Life Options Colorado. Barbara is an emeritus member of the board of directors of the Family Tree in Denver, an organization that serves those affected by child abuse, domestic violence, and homelessness. I looked this organization up. It is very impressive. It looks like the sort of thing that we would want to be supporting if it was here in Boulder County, for sure. She has also served on over 27 volunteer teams in the United States, as well as India, Vietnam, Ecuador, Peru, Tanzania, Paraguay, Guatemala, and Cuba. This woman sounds like a Rotarian who just hasn't found a club yet. So, Barbara, I'd love to have you come up here and enlighten us.
All right. Can you hear me okay? Okay. Well, first, thanks so much for the warm welcome and for the introduction. I am actually very humbled to be here. This is an amazing audience, and I know you have a lot of background and information of your own, so I'm going to try to share with you, and then we'll have some time for questions as well. So I wasn't given a whole lot of time. I'm originally from New York. Some of you might still hear that. So I will try not to speed talk, but we want to get through a lot of information today. We're going to talk about end-of-life choices in Colorado, what they are in general. We're going to drill down and really focus on medical aid in dying in Colorado, but it pertains to other parts of the United States. And then we'll highlight some of the recent changes in our Colorado law. So let's go. First of all, End of Life Options Colorado was born about 2.5 years ago. We're a statewide nonprofit. And as I was discussing with some of the folks at our table earlier, after our statute was passed in Colorado in 2016, those folks I wasn't one of them, they were pretty tired. And I think there was a feeling that we had the new law, which we'll talk about, and all would be fine. And as Constance has alluded to, didn't quite happen that way. We have a lot of work to do in terms of education and access. And so a group of founding members, including some people from Boulder, founded this organization. And our mission really is education and access, so that we can get to all areas of the state and make sure that Coloradans know what choices they have if they're facing a terminal illness and the end of life. So I think this information should be familiar to many of you, but I like to go over it just so we understand where aid in dying fits in this whole spectrum. So in Colorado, we have a number of choices if we face a terminal illness. One, of course, is to continue kind of traditional medical treatments. That means hospital, surgery, chemotherapy, radiation therapy, et cetera. But we also have the option of patient autonomy, and that means that if we decide that some treatments, that the risks and the side effects and the problems overcome the positive effects, we have the choice to stop some or all of those treatments. And I think that goes on very commonly. So someone who decides they don't want to be on a ventilator, they don't want a feeding tube, they don't want any more surgery or chemo or radiation, and we all have the right to make those decisions about our health if we still have the capacity to do so, or we can appoint someone to help with that. Palliative care, I hope, is something that many of you are familiar with. Palliative care is an approach to care, a program of care. It's not a location. Palliative care teams work in many settings, inpatient, ICUs. We're seeing more now in the emergency departments, offices, outpatient, and home-based palliative care. Palliative care is an approach that allows the team to focus on goals of care and symptom control, while patients may still be engaging in more aggressive treatments like chemo and radiation and surgery. So the palliative care team comes alongside and joins the care team to make sure that the goals of care have been identified and that the patient's symptoms are being controlled while they might be going through some of these other treatments. I know there are a lot of folks here who have either been affiliated with hospice or have been hospice volunteers or worked in hospice. So very important, of course, is hospice is also a program of care, and we can receive hospice services in many locations. Hospice addresses the end-of-life needs of patients with terminal illness. And in the United States, we have some requirements which won't surprise you, which is that you have to have a terminal illness with a prognosis expected to be 6 months or less. And we'll talk more about prognosis in just a few minutes. Palliative sedation is something that you may or may not have heard of. It's not as common as some of these other approaches. And we don't see it as much in Colorado, I would say, but there are situations in which a person's symptoms are overwhelming, pain and suffering, and they can't be controlled without using medications that cause a person to be very, very sedated. And so this is a common conundrum for patients with terminal illness. Do I want to be awake enough to interact with my family and my loved ones towards the end, or is my suffering too great and I really need to be basically sedated as I take my last days and weeks? So that is an approach that is rare but can be used. Many of you will have heard about voluntary stopping of eating and drinking. This is also kind of a new kid on the block in terms of end-of-life approaches. There are situations in which aid in dying is not appropriate for a variety of reasons. But in the United States, we all have autonomy about whether we eat or drink and what we eat and drink. And so there are situations in which patients either with terminal illness or other illnesses make the decision that they want to hasten their death by stopping eating and drinking. This approach, as with all of them, really takes a village. It's not easy, as you can imagine. I'm watching lunch thinking about this. It is not easy to stop eating and drinking, and in order to do that and meet a patient's goals, it really takes the support of loved ones, the entire care team, and so forth. And then for today, we're really going to focus on medical aid in dying, sometimes called aid in dying for short. So where can patients receive end-of-life care? Sometimes patients and families, when we say we recommend that you start hospice care, there's a big sigh of relief often, but then there's a presumption that that means that hospice is going to provide all of a person's care. And I think many of you are aware that that's not the case. Hospice provides incredible support in a multidisciplinary manner, but hospice does not provide 24/7 care, and it's just important to remember that. Palliative care, as I mentioned, is with the care teams, and then towards end of life, when we're talking about a focus on aid in dying, we are doing this work in collaboration with the care team, and usually that's the hospice team. So what about aid in dying? Before I get to it, I promise. I just want to remind everyone, this is really important. Medical aid in dying is one tool that we have for those of us who help with end-of-life issues. It is not the only tool that we have in our toolbox, and it is important for patients and their loved ones to understand that if for some reason aid in dying is not appropriate for a patient, that it does not mean we can't have a peaceful, dignified, person-centered death. And so I hope you'll remember that after the rest of this conversation, because on occasion we have situations where we can't qualify a patient for aid in dying, and yet they become very convinced it's the only way to have the kind of death they want. So remember, it's a tool. It's an important tool, but not the only one. So definitions are important and language is important in this conversation. I want to remind you of a couple of things. Medical aid in dying is not euthanasia, it's not suicide, it's not assisted suicide, and it's not physician-assisted suicide. And as we go through this conversation, I think that that is really important to remember. So what is aid in dying? It's the practice of a qualified, and we'll get to that, provider, prescribing medical aid in dying medication to a qualified individual, and we'll talk about what that is, so that the individual can choose to self-administer, and we'll talk about what self-administering is, to bring about a peaceful death. I know this looks kind of complicated, but we can get through it. So, you know, in Colorado, as with 10 other jurisdictions in the United States, we have a statute that allows providers to prescribe medication to those individuals who are eligible and who qualify. So in terms of being a qualified provider, in Colorado, this just changed last summer, a qualified provider is either a physician or an advanced practice nurse who can act as either the attending or the consulting physician. A qualified patient is someone who meets these criteria, and they're really important. And this sometimes looks overwhelming when we first talk with patients and their loved ones, but we can get through these issues in a very steady way. So you have to be over 18. I'm sure that doesn't surprise you. You have to have a terminal illness, which is a conversation we could have for a long time, but a terminal illness with an expected prognosis of 6 months or less. You have to have decisional capacity, have to be able to self-administer, and at present you have to be a resident of the state of Colorado. An important reminder is that the whole thing with end-of-life care in general, and in particular aid in dying, is the patient is in the driver's seat. So the patient is making these decisions, and only the patient. There's no requirement that the patients proceed at any particular pace. And even patients who get through this whole qualifying process, of course, there's no coercion to take the medication at any point. And what we know both in Colorado and in the United States is that about 30% of those who have gone through this whole process and could receive a prescription may not use the prescription. And what we hear, I think is really important, is that patients feel a great relief, that their wishes are being respected, that they have an option if they need it, and this takes away a lot of anxiety and suffering in their last days. I'll share with you that I saw a patient day before yesterday with a terminal illness and a lot of suffering. And after I spent some time with him for his first visit, when I was closing the visit and we were finishing our plans, what he said to me was, "Thank you so much for coming. You've lifted this huge burden off my chest." And I think that that is one of the most poignant things we hear. Whether or not he proceeds or not is not really the issue. It's listening to patients and respecting their wishes that, in my mind, is really important. The process for qualifying as a patient sounds a little bit burdensome, but we can get through it. I keep a spreadsheet on every patient so we don't lose track of anything. Basically, patients have to make a first request to the attending provider that makes sure they understand what their diagnosis is, what the possible treatments are, what the outcome of taking the medication is. The clinician has to assure that the person has decisional capacity. And I apologize, this slide, oh yeah, it does have the 7 days, sorry. So we used to have a 14-day waiting period in Colorado. We're now down to 7 days, which just decreases the amount of time for those persons whose suffering is really accelerating. The patient has to have an evaluation by a consulting provider. Now it can be a nurse practitioner, advanced practice nurse, or a physician, to confirm the diagnosis, confirm the prognosis, confirm that the patient has decisional capacity, and that there's no coercion. There has to be a written request and a second request, which occurs after the waiting period that goes to the attending person. When all those steps are done, which we can sometimes do pretty quickly, as far as I'm concerned, that's when the work really begins. The updates to the law, some of you are aware of, and I've mentioned already, the changes in the 7-day waiting period, and then allowing the addition of advanced practice nurses to act as either the attending or consulting provider. We had hoped that the residency requirement would be dropped. That did not occur, in case you had heard conflicting things about that. So we still have a residency requirement in Colorado. So I just want to spend the little time I have left on, kind of what it's like and what I think of as evidence-based practice. So, we go through the legal part of this, which is extremely important. We go through trying to understand what a patient's goals are, and that they understand what they're asking for. And then as far as I'm concerned, this is where the art and science of medicine have to come together to make sure that the patient remains appropriate from a medical point of view, to determine that hospice enrollment has occurred. This is not required by the law, but as you can imagine, having hospice support during this time is critically important. And although we can't, again, the law doesn't insist on that, most of us practicing are very insistent that our patients have hospice enrollment. I lost my slides, but I'll keep talking. That's okay. That's all right. You'd think I would know it all, right? That's okay. I think this went, let's see. There we go. Okay. So in my practice, and I have a small consulting practice in addition to my work with our nonprofit, I believe in continuity and staying in touch with my patients as long as it takes. And so after we finish the qualifying process, I stay in touch with patients as to when their day of ingestion is going to be, what their plan's going to be, and I actually attend the day of ingestion if possible, if it's not someone in another part of the state where we're doing virtual work. So again, we talk about the hospice enrollment, pharmacy recommendation, and again, the constant assessment of how the patient is doing. I used to use the word, because we want to make sure it's safe to proceed. That seems strange since we're talking about a lethal outcome. So I currently have switched to using the word effective. And the reason I say that is these medications are given into the GI tract, and we'll talk about that in a minute. And if your GI tract isn't working or there are other medical complications, there are rare situations in which aid in dying is not going to work. And we want to try to avoid getting into that situation. And that's why we reassess patients before we do the prescriptions. For those of you who have watched some of the older films about aid in dying, like How to Die in Oregon, and some of those, you'll remember the days of pills and Seconal. And I had a patient last week when they called who said, well, can't you I just want to have that pill. I want to have it in my bedside table so I know I can just take it. Well, I'm here to tell you those days are over. Seconal is a barbiturate. It was used for many years for aid in dying. If you watched How to Die in Oregon, there's a scene where there are families in the kitchen opening 100 tablets of Seconal to get the powder. Okay, so those days are over, which I think is a good thing. We don't have a pill anymore, and we really have to explain that. We have a combination of medications, and they're lethal, and so we have to be really careful about those. Routes of administration, not to get too technical for this audience, when the statute was first passed, I think there was an assumption that the medications had to go in by mouth. Turns out the statute really specifies self-administration into the GI tract. And so in the past number of years, we've been able to use people taking the medication by mouth, people using tubes in various places like in the stomach, or now the most recent addition is rectal administration of these medications in certain situations where if the upper GI tract is blocked or not working, but the rest of the GI tract is working, we can use the rectum as a method of administration. Are there any pharmacists here? I don't want anybody to faint when they see these doses. I guess Hans is not here, the resident pharmacist. So for the clinicians in the room, don't fall out of your chairs. And for the non-clinicians, let's just say these are ginormous doses of these medications. And the medications are compounded by a variety of pharmacies in Colorado into a powder. And what I want you to know about this is, one, these are huge lethal doses, and we choose, this is the combination that we've come to after many years of, believe it or not, research into this field and summarizing data to see which combination is going to be the most effective. And basically, this set of medication works because it works on different parts of our body. So it works on our heart and our brain and our lungs and our neurologic system. And that's really all you need to know. We don't have to teach the pharmacology part today. Self-administration, of course, is a requirement of all jurisdictions in the United States. The patient has to either drink the medication like we talked about, or in the case of tubes in a variety of places, has to be able to depress a syringe or start a drip with their hand, or some people their foot, and that defines self-administration. There is no jurisdiction in the United States where self-administration intravenously is legal, just so you know that. We often get questions about that. But it doesn't mean that loved ones, caregivers, hospice staff can't assist patients. And I think that's really important. So someone can hold the cup, someone can mix the medication, someone can help with the straw. In the situation of rectal administration, someone can hold the base of the connector so that things don't fall apart. But the patient has to be able to do the self-administration. I want to back up. I realize my slide about decisional capacity got lost in me trying to make this talk a little bit shorter. So let me make a comment about decisional capacity, because that question comes up a lot in terms of all patients, but particularly patients with possibly some cognitive impairment. So, in medicine and in the law, competence is decided by the courts. I hope we don't end up having to be in the courts. And decisional capacity is a clinical determination. And I think it's really important that we understand the way decisional capacity is not all or none, and I'm sure all of you understand this. So there are some things that we might have the capacity to make decisions about, like what we want to wear or what we want to have for breakfast or who we want to be with, that we can make, but we might have impairment enough that we can't make a detailed financial decision or a detailed medical decision. So when we assess patients for decisional capacity, in terms of aid in dying, we ask very specific questions that we have to feel reassured about for everybody. And so that's, what's your diagnosis? What's your understanding of your prognosis? Do you know what the alternatives are to this? Is anyone forcing you into this? And I always say to patients, and sometimes they laugh actually, if you take this medication, what will happen? We have to hear that. We have to hear patients understand that if they drink down the medication or have it through a tube, that it's going to cause their death. It's really important. But does it mean that the patient needs to know the day of the week, or who the president is, or what their street address is? Actually not. And so we have to be really clear about decisional capacity. I think there might be some questions about dementia and advanced care planning for dementia that I think we'll save for the question and answer period. So the aid in dying day, because people are always concerned about this, I think every clinician participates in different ways, but the main thing, and I've learned this from my 27 teams as team leader, is we have to have plan A, B, and C. And so I spend a lot of time with patients and their loved ones and their care team understanding what the aid in dying day is going to be like, so that if there are unexpected things, we know how to handle those. So a lot of discussion, integration with the pharmacy. A big one is who's going to be there. We think, the patient wants to be surrounded by their loved ones, sometimes, but not always. Some family members are very supportive, but they don't feel they can be at the bedside. So I like to have that conversation up front. Who's going to be there? What have they experienced before? Review of this red flag, we've changed to risk factors in our language, but it's to make sure that we think the medication will still be effective. We have to reassess decisional capacity. very important before the day of ingestion. And then, this is hard, but we talk about what the post-death plans are in terms of grief, funeral home, post-death planning, things that hospice folks are well aware of and are doing all the time. And then on the aid in dying day, as I said, I personally like to attend. That's not always possible for myself or for my colleagues, but I think that with good preparation, loved ones and the right care team can do this without a clinician there if there aren't outstanding medical issues. But when I am there, I spend a lot of time with the friends and loved ones, talking about last words. We use pre-medication to decrease nausea and vomiting. That makes people a little bit sleepy. And then the medications work very quickly. And so we recommend last words, last songs, last music, whatever the wish is, before the ingestion starts, because patients often will fall asleep very quickly. And then people say, well, what's it like anyway? And some people in the room have experienced this, but have attended when someone is using aid in dying. My experience, having been at quite a number of aid in dying deaths, is that with the right preparation, these patients are generally incredibly resilient and stoic, have made their decision and stick with their decision. And once everything's in place, this is generally a very peaceful and respectful way to take one's last breath. So the patient ingests the medication. Most patients will be deeply, deeply asleep within 5 to 10 minutes. And we prepare loved ones for what that's going to be like. The majority of patients will take their last breath and their heart will stop in 1 to 2 hours with our current formulation, and it's very peaceful. But as with everything in medicine, it depends. So I also spend a lot of time preparing loved ones for the occasion where it's going to take longer than 2 hours, or where there's going to be some hiccup, literally, in the situation. So we know how we're going to handle that situation if it happens. So the average time to death now is, again, under 2 hours for most patients. After the patient dies, the usual, presuming the patient has hospice care in place, the usual hospice policies go into place. The hospice nurse comes and checks the patient if they're not already in the home, talks to the medical director or the attending provider, calls the coroner who quote unquote releases the body, and then the hospice nurse calls the funeral home. So if all these things are in place ahead of time, you can see why that's so important for a time of grief and sadness for this to go smoothly. And it's a really important reason to have hospice services in place. I want to highlight here, because there's always questions about this, that the death certificate will note the terminal illness as the cause of death. Aid in dying is not the cause of death. These patients are dying of their terminal illness, and that is on the death certificate, and that's actually outlined in our statute. After death requirements in Colorado, we're actually working on. Some of us would like to see more robust data collection. But there are certain forms that the attending clinician has to fill out, as well as the pharmacist, and then the death certificate, again, assigned either by the hospice medical director or the attending clinician. There are very, very, very rare circumstances where hospice is not involved, and then there are some details that have to be worked out so that we prevent law enforcement from getting involved. You may be aware that if there's an unattended death in the community where hospice is not involved, in general, law enforcement does get involved. So we try to avoid that by contacting the coroner ahead of time if we can. Cost is an increasing issue, as it is with all health care. I won't go into all the details, but due to a law that was passed in 1997, Assisted Suicide Act, federal dollars are prohibited from being used for anything related to assisted suicide. Now, if you remember what I said 20 minutes ago, aid in dying is not assisted suicide. In fact, our statute says that, but the legal world has taken on its own life, and for this reason, Medicare and Medicaid, with one exception, don't cover any of the cost. And then, of course, commercial insurers tend to follow that. And so there's essentially no insurance coverage for either the clinician services or the medications. And so right now, the medications are increasing somewhere between $500 and almost $1,000, depending on where we get the medication. And provider fee schedule is kind of variable. At End of Life Options Colorado last year, when we realized what was going on, and as we try to reach other areas of the state where resources financially may be even more of an issue, we did develop a patient assistance fund specifically for medications. So note that somewhere in case you ever have someone who might need help with medications. We're able to help with that. Okay. Lastly, it won't surprise you, as with everything in medicine, that there are some ethical dilemmas I think that we all think about all the time. This is important work, it's challenging work, and at least the colleagues I work with take this very seriously and think about these questions all the time. So we've talked about the issue about language and why misinterpretation should be avoided if possible, although it's common. I want to highlight that diagnostic and prognostic challenges are really common. I was just on a call yesterday about this. When I was in ambulatory practice, I saw my patients over many years, sometimes decades, and when my patients hit about 95, I had one in particular, she said, well, I'm ready, aid in dying. And I said, well, you don't have a terminal illness. And I am not wishing one on you, but I cannot do this. And she said, well, don't you think being 95 is a terminal illness? Okay, so it's hard to counter that. But I was, Constance and I were talking about this before. The onus is on clinicians to follow the law to the best of our ability. We may not agree with all aspects of it, but we do have to follow it. So, this diagnoses and prognoses are not perfect in medicine. Decades ago when I was just out of residency, I would have said, oh yeah, I can tell you who's terminal and I can tell you how long they're going to live. Not so. But we need to use the best evidence we have, both clinically and from our experience with patients, to make these determinations. That's all we can do. And in the rare circumstance, which is rare, but it happens, when patients don't qualify because they don't have a terminal illness, or they have a longer prognosis, or they don't have decisional capacity, the onus is on clinicians, in my opinion, to help them through whatever their challenges are, to make sure that they're getting care, that their care team is aware of what's going on, and not just abandon and say, well, no, you don't qualify, so, out of here. I think it's a really important issue. Some of the hardest situations I've had is when I've either already qualified a patient who then loses decisional capacity, and we have to change plans, or someone who just really doesn't qualify from the get-go. And those are very difficult conversations. And then I consider this an ethical issue. I don't know if you do, but I think access in our state is a really big issue. And it's not just related to aid in dying, but to other aspects of medical care. We know, and I didn't have time to present the data to you, but we know that in Colorado, as in the other states, probably almost 90% of our patients are white, well-resourced, highly educated. And so it's an area that we, as an organization, are really working on to expand access and education, not to force anything on anyone, but so people know what their choices are and what questions they can ask. All right. So in summary, there are a lot of choices for end-of-life care for Coloradans, and aid in dying is one of them, but please remember it's not the only choice. The end-of-life options statute in Colorado has a lot of detail, and it looks overwhelming, but going through it carefully, it is possible to achieve this for patients and their loved ones. I think that the evidence shows that there's no coercion, that patients and families have used this option appropriately, and the onus is on clinicians, I think, to have high integrity in using this approach. And then, as I mentioned, there are some barriers to aid in dying, not only in Colorado, but all over the United States, and hopefully we will see improvements in those areas in the future. So, Thank you for having me. I do have over on the tables when you're leaving, I know you want pens, because everybody likes pens. There are pens over there, but there's also a card about our organization, and there's a QR code to get to our website as well. You can contact me directly. My cards are on the table as well, or you can send a contact through our organization. And then my last plug, and I actually didn't bring a summary because I did these slides a while ago, is we are thrilled to announce that we are having our first inaugural conference in Denver in early June. It's a conference aimed for education for health professionals, really to empower health professionals to understand aid in dying and to be able to provide that care compassionately and in a person-centered way. That information is on our website as well. There are still places, spots available for that conference if you're interested. And I think we can take questions.
Yes. I just want to say that there's probably going to be a lot of questions, but we really only have about 5 minutes, okay?
Thank you so much for that. I've spent a good part of my career being a visiting nurse and a geriatric care manager. My question is, what happens if the patient's doctor, for whatever reasons, ethical or religious, says, I can't participate in this? What does the patient do?
Great question, thank you. I call this restricted settings. So that's when either the clinician can't or won't prescribe or participate based on either their own values, which you've mentioned, or because their organization is opting out of participating. The law requires actually that health systems and clinicians then are collaborative in making referrals. Which sounds maybe easier than it is. But I will tell you that part of our work is to help connect clinicians and patients in that situation where their care team is unwilling or unable to help. So if you go to our website, there's a page for, that says clinical resources. We are very proud as one of the few states that we actually have folks listed who are willing to help patients. And we also have folks we know of, if we get a contact, that we can help with. Used to be kind of the secret club. It's not so secret anymore, which we're very happy about. So we can get help for patients.
I'll bite. You suggested that someone might ask about options for people with dementia. What are the end-of-life options for people with dementia?
Okay, so that's not thank you. That's a whole nother presentation. So many of you are aware that the dementing illnesses, Alzheimer's and others, by the time you would qualify as having a terminal illness is beyond when you would have decisional capacity. So that's why in all the jurisdictions in the United States, dementia alone does not qualify you because it's not a terminal illness at the time. But many people have said, well, wait a minute, I don't want to live like my mother, my grandmother, whoever, and I want to be able to predict for the future demented person what will happen. So there's a lot of work being done on advanced directives for patients with dementia and early memory impairment so that you can really lay out what your wishes are. People are making videos about what they want. Some patients are using VSED because we can't use aid in dying, where they lay out, if I get to the point where I don't recognize my children, I don't know where I am, et cetera, this is what I want VSED. There are situations where that's not what people want, and some of you may have read Amy Bloom's book about taking her husband, I see some head nodding, to Europe, to Dignitas. There are some situations in Europe where they will help with aid in dying with patients with memory impairment, but there's a time frame there, and you have to apply, and it's kind of difficult. What I would say right now is in the United States, and this is a whole nother conversation about advanced directives, is there are a lot of things that can help with your wishes if you're the person who's making decisions for you, if you can't make decisions, can help with this. And they sound basic, but they're really important. So if I have memory impairment, it's getting worse, and I tell my loved ones, I don't want to go to the hospital, I don't want to have a surgery, I don't want antibiotics, that can all be controlled and is legal. And so it's really important to talk about those things in the meantime. And then more work to be done on this issue of advanced directives, particularly for patients with dementing illnesses.
Yes, I'm 91, and many years ago, my spouse had selected not to eat or drink in her end years. It was in another state with the largest hospice in the nation of 20,000 employees.
Wow.
And a lot of politics in that situation. What is the difference in Colorado and other states as the one I was in, and even across the U.S. and variations of this subject?
I'm not sure I understand the question. What's the difference in how hospices manage it?
Yeah.
Oh, okay.
And the state regulations.
Oh, and the state regulations. For aid and dying or for VSED? For aid and dying? For VSED? Okay. That's a really good question, actually. You know, VSED is not, it's legal because we have the right to stop eating and drinking. So I think the bigger issue is how hospices are being trained and how staff are learning to understand the whole VSED process and support their clients. And not only in Colorado, but all over the U.S., we have so many hospices now, and they keep changing names, and it's really difficult. And one of our goals, actually, with our conference is to help make sure that frontline staff understand, particularly aid and dying, but also VSED. Because it's important for the staff to understand what those processes are like, what the policies are of the hospices. I won't get into the whole issue about hospices and how much they participate or don't participate in aid and dying. I'll just tell you that in Colorado we have a huge spectrum. So we have some hospices who won't even talk to patients about it, won't give information. That's rare. We have many hospices in the middle who are supportive of a patient's choice, respectful, will collaborate with people like me in providing the medication, but won't allow their staff to help with self-administration or mix meds or be in the room. And then we have a few hospices, and we hope to see more, where it's an even more collaborative process where the hospice medical folks are able to do the prescribing and actually be all in. We have a lot of work to do in Colorado before we get to that point, though.
Okay. Barbara, I want to thank you for a really excellent talk. And, you know, I had 33 years of practice, and some of them, toward the end, I did a lot of medical aid and dying and hospice, you know, getting people to accept hospice. I think the U.S. still has a problem of people's fear of what dying is like. And I just want to quickly read this quote from Elizabeth Kubler-Ross, which I'm sure all of you have heard of because she was one of the ones who started this whole hospice thing. Those who have the strength and the love to sit with a dying patient in the silence that goes beyond words will know that this moment is neither frightening nor painful, but a peaceful cessation of the functioning of the body. And I think that's important for people to learn. I mean, it doesn't have to be a scary thing. That's the main point. But on a happier note, you may not know that Rotary is very involved and has been for many years in the work to stop polio throughout the world. And in honor of your speaking to us, we would like to contribute 100 doses of polio vaccine to the Polio Plus Fund.